name is Alain Astier. I'm from Paris, France. I'm professor of clinical pharmacy and biotechnology at the University of Paris, and the hospital pharmacy is the Henri hospitals in the same country and the same city. Okay, it's a pleasure to have my colleagues, the Professor El Hafiz. Okay, thanks a lot. And we will speak this morning about nutrition. Nutrition is a very important factor in cancer in general, because there is two kinds of problems. The problem is the undernutrition of patients in general, it's very common. And it has been also demonstrated that if we improve the nutritional status of the patients, you can improve the output in terms of chemotherapy. It's very, very strictly correlated. It's very important not only to treat the patient, but only to treat the patient in the best conditions possible. The second problem, very important for pharmacists, are the interactions between the drugs, oral drugs, and the foods. Okay? Because more and more we have to use drugs by oral route in oncology, and the problem of all drugs by oral route is the problem of interactions, not only interaction between the drugs, but interaction between drugs and the foods or liquids, and it's very, very important. Okay? We will start with the first presentation, which is the parenteral nutrition, which is a very important topic, and it's a pleasure to introduce Dr. Selim. Okay.
It's a pleasure for me to be here with you today. على الرغم من إن the number of audience is very small, but we will start. Malnutrition in different diseases, as we in a malignancy and cancer conference, the prevalence of malignancy due to malnutrition in different diseases is the highest due to cancer disease. What are the clinical effects of malnutrition? There are many: psychological, decrease in immunity, decreased cardiac output, decreased renal function, hypothermia, loss of muscle strength, anorexia, impaired GIT integrity, which may lead to sepsis and death, which is a main risk factor here for our patients who take chemotherapy and is accompanied by GIT symptoms as stomatitis and oropharyngeal infection. Impaired bone healing, which is a main risk factor, which as a result of it, increased length of hospital stay, which means increase the costs, which is a very essential for hospitals. Liver disease and ventilation due to loss of muscle mass. So, malnutrition is a nutrition problem in hospitalized patients. Nearly 75% of patients undergo malnutrition. 30 to 50% of them after admission to the hospital. So, other nutrition screening and assessment is a mandatory. So, we have to start by patient screening on admission. What is screening? Screening, the process of identifying patients with characters commonly associated with nutritional problem may require comprehensive nutrition assessment. That means screening may have to be continued by assessment. Screening, our aim from it is to know who is present with malnutrition and who is high risk of malnutrition through simple methods. Example of this method is the MUST, Malnutrition Universal Screening Tool. It has 3 steps. The first step, determination of body mass index to determine if the patient is malnourished or not according to his body mass index, if less than 18 and 18.5. Then the unintentional weight loss, the history of weight loss for this patient, for how much, 3 or 6 months of weight loss during this period, and the chronic diseases accompanied for this patient. We have to make risk scoring, and according to the score we can determine the patient is at risk or will be at risk. Another screening tool, patient generation subjective assessment. 2 papers, one for the patient and one for the health care facility. First of all, asking about the weight, the symptoms, the food intake, and the additional functions and the physical activity. And this scoring for all the previous. Then nutrition assessment. It's a comprehensive approach to define nutrition status using medical, nutritional, medication history, physical examination, anthropometric measurement, and laboratory tests. Assessment should be easy, cheap, reproducible, can predict the state, available, have little variability, and little time intake. Can indicate weight loss for the overall chemotherapy cycles. Nutrition assessment first through body measurement and body composition, which are the anthropometric measurements, laboratory tests, and physical examination, clinical observation, and finally dietary analysis. Example of it, 24-hour report to know what the patient took the last 24 patient on parenteral nutrition, there must be daily round and monitor for drug-nutrient interactions. In the past, the physician was the only profession who is responsible for nutrition for the patient. Nowadays, no responsibility for compounding for safe parenteral nutrition and mixed for patient and oral or enteral is the responsibility of the pharmacist. The scope of practice of the nutrition support team included for the pharmacist assessment, development and implementation of the nutritional plan, compounding, monitoring, services, advancement and research. Here is a nutritional plan in formulation route. The physician and dietitian and the pharmacist are responsible in how to determine the axis and choosing the physician and the nurse. Delivery method is decided by both pharmacist and dietitian with the nurse. Monitoring, all of the team are responsible for the monitoring. The role of each individual in provision of patient care can vary from one hospital to hospital according to the strategy and the plan for this hospital. Because of the potential clinical relevant impact of nutritional intervention on quality of life, daily plan for nutritional therapy is incorporated into nursing care plan. After screening and assessment, the assessment is done to start the nutritional plan. First of all, we are going to initiate nutrition if the patient is hemodynamically stable. Hemodynamically stable means that he is tolerating fluids and his blood pressure and blood flow and cardiac output is within normal ranges. If the patient is any type of shock, respiratory, cardiogenic, hemorrhagic, septic shocks, he is unstable patient. So, hemodynamic instability means body cells do not receive enough oxygen. So, we have this recommendation from our professor, Dr. Saeed Al-Kasha, professor of anesthesia. It says it's forbidden, according to recent guidelines, to give parenteral nutrition for hemodynamically unstable patients, which means patients on vasopressor or patients in shock. We have to define it as low dose vasopressor can result in a hemodynamically stable patient, so we can start nutrition if the patient is stable on a low dose vasopressor. This paper was done because a physician insists to have a nutritional support for this patient, and the patient was hemodynamically unstable. And he said to me, I'm going to take you to the police office if you didn't start. Then, if the patient is hemodynamically stable, so normally we will start initiating enteral nutrition. Enteral nutrition started within 24 hours on admission. As we see in this schedule, the intake for the enteral nutrition is increasing. Why? To avoid refeeding syndrome. What is refeeding syndrome? It's a symptoms characterized by decreasing of body mass index less than 16, or unintentional weight loss, or if intake of food is low or no intake through for the previous 10 days, or lab parameters is inadequate, especially electrolytes. So we are afraid of refeeding syndrome. What happens if we give a patient off oral for nearly 10 days, or cancer patient, he doesn't take his needs, we give him the normal intake. The body cells shift from catabolic state to a high anabolic state, resulting in high insulin release, which means increasing intakes of all nutrients taken in the body. We are aiming to have an increase in electrolytes and having the balance. No, that fact we will suddenly have to see in decreasing all electrolytes, hypophosphatemia, hypokalemia, all electrolytes are decreasing in it was shrinked, and after nutrition, it will be swollen due to higher EPA. Then, this will result in relative ATP deficiency, which lead to failure in cardiac muscles and may lead to death due to respiratory failure. How to overcome and minimize prevention this refeeding syndrome? By start low and go slow. How to give minimum amounts of glucose, which is 2 grams per kg for all the day, or 125 to 150 grams per day for starting, then increasing gradually till have all the needs at nearly 1 week after starting of the nutrition. After starting nutrition, oral nutrition, if it's failed, the patient can't tolerate enteral nutrition, or having any of these signs, fistula, obstruction, inflammatory bowel disease, and his needs can't be adequately met by the enteral nutrition, so we have to shift to parenteral nutrition. And this is our main topic today. So, how parenteral nutrition is delivered? Delivered through a multi-bottle system, which is the main system commonly used in most hospitals in Egypt and other countries, which means each bottle is separately hanged for the patient. So the use of separate bottles, which requires multiple manipulation, high risk of microbial contamination, poorly adapted to the patient requirement. Osmolarity. What is osmolarity? It's a concentration of the solute in the solvent. How many particles are present? We have to consider the osmolarity, especially if we are giving the patient peripheral parenteral nutrition. As we can see, glycophos, which is phosphorus, organic phosphorus, the osmolarity 2.75 milliosmol. In osmol, it's 2076. The maximum tolerable osmolarity for peripheral injected medications is 900. So it's risky to give either trace elements, which is 3,100, and the glycophos, organic phosphorus, 2,700. They have to be administered either centrally or diluted for a long time to avoid thrombophlebitis and losing the vein. Another issue in separate bottles, we have to restore amino acids as a source of energy, not as a source of energy. We have to restore it for anabolism, for proteins. So if we give amino acids alone, singly in a separate line, so the body will see this amino acid as a source of energy. As 1 gram of amino acid results in 4 kilocalories, and 1 gram of carbohydrate results in 4 kilocalories. So we have to administer glucose and amino acids in the same time in 2 parallel different lines. If we are having peripheral, if central, at the same time the 2 bottles are infused. 2-in-1 system, glucose system, mainly used in NICUs and units, which are in incubators, to avoid mixing of lipids with the amino acids and the glucose. The last system, which is 3-in-1 system, all-in-one system, or lipid system. Advantages of it: through one intravenous line, but made infused by a pump, continuous and simultaneous, optimize nutrient utility, as all are administered at the same time, so each one will be utilized in the body as its needs. High microbiological safety, minimum manipulation and monitoring, reducing the load for the nursing staff. Our history for Alexandria University Hospital Parenteral Nutrition Unit, which is the only parenteral nutrition unit having automated system in Egypt. لا معلش. احنا لسه في المهم. Dr. Magda Dawish is our global head of pharmaceutical affairs. So the automated system in Dubai conference, and with Virginia Scabby, and they give this apparatus for us as a donation. The plan was started 2005. The implementation of the unit launching was done. How to request a parental nutrition pharmacist by a telephone or a clinical pharmacist in a round, or a physician visit to the unit, or outpatient needs parental nutrition for the outside. Daily round is done. Physician and the nurse with the clinical pharmacist, parental nutrition. Lab parameter should be revised. How to write a parental nutrition sheet? We have to know gender, age, height, weight, temperature, any volume restriction, how many calories is needed, how many days is the patient going to be off oral, how many expected to receive parental nutrition, any renal or hepatic impairment, the ratio between fat and carbohydrate, and how much protein. All are written in the order, parental nutrition order, which is signed by the physician. The physician sign is a mandatory. No parental nutrition sheet can be prepared without the physician assent. How to calculate the needs? Calculation in the round is done by nearly all the people, all the nutrition specialists, carried by the quick method with the appropriate reference weight. In our hospital, and by using the automated system, the calculation is done by the Harris-Bandick equation, and so we have to use the sex, the weight, the height, the age to incorporate it in the equation. Quick method, we don't need to use all these. Calculation is done. This is the picture of the area. It's 3 chambers, A, B, C, containing a HEPA filter, clean condition, having a horizontal laminar airflow for preparation and the vertical laminar airflow. HEPA filters are in the central air condition, receiving nutrition to the unit, entering the data. The calculation is done twice, one time by the clinical pharmacist in the round, and revised by the automated system in the unit by different equations. The two methods are not the same, but nearly the results are the same. The multi-compounding system is attached to the computer system through pumps, and after putting the order, the pumps start to suck the nutrients into the bag. And the bag is filled according to the needs. The balance for a secondary check. Infection control measures are done for both the bag and the environment we are preparing, and alhamdulillah, all of them were sterile. How to calculate the infusion rate, which is a very essential to avoid many signs and symptoms. Sometimes we in the round, the physician say the patient is having high rate, diarrhea. The patient is feverish. All these are from the milky bag you are handing it to them. First of all, we have to think about the rate of infusion. If the rate of infusion is wrong, all signs and symptoms of diarrhea and cramps and heart pain, all of the symptoms you can imagine will happen to the patient. Route of administration, either peripheral or central, according to the osmolarity of the bag prepared and to the needs of the patient. Do not let your patients starve, and when you offer them nutrition support, do so by the safest, most simple, and effective method. Merci.
Thank you. Okay, maybe we will have the question at the end of the presentation as preview in the programs. Please.
Thank you so much. My pleasure to introduce Dr. Rasha Galel and her presentation about food safety and storage. Thank you so much.
The topic we will be discussing today, it's not the typical scientific topic related to medicine, but it's an important topic that is usually overlooked because of the very few numbers that are reported concerning food safety.
Pointer? دكتور في حل جاي هشوف.
لا خلاص.
معلش.
Okay, first of all, yes. I will try to finish before even the 18 minutes. I try to keep it short and simple because I know the topic is not really the topic used in conferences such as this. First of all, a few key facts about food safety. Access to sufficient amounts of safe and nutritious foods is key to sustaining life. And as we are talking here in this conference about cancer patients, and so this category of patients are immunocompromised, so taking care of what they eat is as important as the medication they are taking. So access to sufficient amounts of safe and nutritious food is key to sustaining life and promoting good health. Unsafe food containing harmful bacteria, viruses, parasites, or even chemicals causes more than 200 diseases ranging from diarrhea to cancers, but usually the relation is not easily done. Unsafe food creates a vicious cycle of disease and malnutrition, particularly affecting infants, young children, and sick people, and any category of people with immunocompromised systems. Foodborne diseases impede, of course, socioeconomic development by straining healthcare systems, and even affecting tourism and economies, because if a country is known that its food is not safe, it will affect people eating and coming visiting these countries. The very threat of foodborne diseases to public health and welfare and to the economy has often been underestimated due to causal relationships between food contamination and resulting illness or death. What is a foodborne illness? A foodborne illness is a disease transmitted to people by food. And the new thing, or the thing that most of the people don't know, is that an illness is considered a foodborne illness outbreak if only two or more report same symptoms after eating the same food. Usually, if a family had dinner in a restaurant and two of them have the same symptoms after eating the same food, they just take it as, okay, we must have eaten something bad and it's overcome. Nobody reports any foodborne outbreak. So if two only report the same symptoms, it should be reported because it will be considered an outbreak. Even in hospitals, anywhere where food is served. The main symptoms of a simple foodborne illness is diarrhea, vomiting, fever, nausea, abdominal cramps, and sometimes jaundice. Types of food contaminants. The most common are the biological, whether viruses, bacteria, fungi, and parasites. We also have chemical contaminants such as cleaners and sanitizers used in cleaning the place where the food is prepared, and used in cleaning if they are in high concentrations and not cleaned properly enough. And physical contaminants like glass, dirt you might find in food. Even a fish bone is considered a contaminant if you are ordering a fish fillet. If a person ordering a fish fillet finds a bone in it, it's considered a food contaminant. Populations of high risk for foodborne illness, as we said before, anybody with a compromised immune system, such as preschool children, elderly people, people with compromised immune systems, and pregnant women. Food most likely to become unsafe, and they are called time and temperature control for safety food. These are the categories which need control. They cannot be left outside for a long time, otherwise they deteriorate easily and bacteria grow very quickly in the milk and dairy products, meat, poultry, eggs, fish, shellfish, heat-treated plant foods such as cooked rice, and all what we will be discussing here can be applied at home, can be applied in a restaurant, can be applied in hospitals, especially in hospitals where food is served on a daily basis. So for example, it's very easy for us to leave the cooked rice from the time it was cooked, like 3 p.m. till 9 p.m. on the stove, and anybody coming, he can eat, or he or she can eat. But this is totally unsafe. If the rice stays after 4 hours in room temperature, it should be thrown, because it will develop bacteria, viruses, and not viruses, but bacteria, and it will be dangerous for anybody with a compromised immune system. Baked potatoes, the same. Sliced melons, cut tomatoes, and cut leafy greens. The tomato or any vegetable, as long as it is intact, it is safe to leave outside in room temperature. Once it is cut, it should be refrigerated immediately. What bacteria need to grow? We call it fat tom. These are the main criteria. Bacteria need to grow and to grow in numbers. First of all, it needs food, especially carbohydrates and proteins. Acidity, bacteria grow in little or no acid. The temperature, we have the temperature danger zone, which is from 5 degrees centigrade to 57. This is the danger, and we have in between most dangerous from 21 to 52, and I think this is the temperature that in a hot country like Egypt, this is the typical temperature, room temperature, which is above 21, so leaving food outside is really dangerous. It also needs time, oxygen, although some bacteria grow without oxygen, and moisture. Bacteria need high levels of moisture to grow fast. So first of all, what do we do to prevent contamination. First of all, personal hygiene, hand washing, and preventing bare hand contact with ready-to-eat food. As much as possible, I should wash my hands at all times and prevent bare hand contact with ready-to-eat food. And we mean by ready-to-eat food something that anybody can come and eat immediately. It doesn't need to be cooked or handled before eating. Use gloves, maintaining personal cleanliness, restraining hair, and removing jewelry while preparing food, and covering wounds. When to wash our hands? Many of these are obvious: after using bathrooms, touching hair, face or body, sneezing, coughing, or even smoking. Also after taking out the garbage and handling money, which is a point usually forgotten, but money is really a very high source of microorganisms, or touching even our clothes. This is the typical flow of food cycle for any, it can apply even to the household, but for any hospital serving food, this is the typical from purchasing, receiving, storing, preparing, then cooking, holding, and by holding we mean that we keep the food till it is served. It is cooked already, but we keep it till it is served, and then cooling it in the fridge, reheating if food is in the fridge and we need to reheat it, and then finally serving it. General inspection guidelines when shopping. So we will go through the past cycle quickly on each item and see together how we can stop contamination during each of these cycles. First of all, during shopping, do not buy items with tears, holes, and punctures in their packaging. Do not buy cans with labels that are not intact or have bulging or swelling ends or rust or dents. And usually during offers in large supermarkets, you find many of the cans, they have dents. A dent is a serious thing in a can, so never buy cans with dents, and do not buy vacuum packed meat if the packaging is bloated or leaking. You can see it, for example, blood is around the package, so don't buy these items. Do not buy items with broken cartons or seals, or items with dirty or discolored packaging. Do not buy items, or especially items put in paper bags where you can see that a watermark, because this means it was wet at some time and then it dried. Also very important, do not buy frozen items where you can see crystals in the frozen item, because it means that this item has been thawed and then refrozen again, which means that it's not safe to eat. Purchase eggs from the refrigerated section. Usually here in Egypt specifically, we are used to buying eggs not in the refrigerated section, but eggs must be kept in the refrigerated section, and at home or in a refrigerator, they should be put in the refrigerator itself, not in the door as we are all used, because they have these racks in the door, because the temperature in the door is higher than, and they should be kept at 5 degrees. Don't buy food that is missing expiration or used before date, and do not buy meat, fish, or poultry that is sticky or slimy or doesn't look clean, and don't buy food that has a bad odor. When storing your fridge, food in the fridge, whether it's at home or in a food serving facility, at the top must come the ready-to-eat food, and the concept for stacking the refrigerator is preventing dripping, dripping of any liquids from one rack to the other. For example, if we put the poultry at the top, it's still uncooked, then it might drip some of it, the water it has, and so as long as it is not cooked, then there is bacteria. So if it dripped on ready-to-eat food, then the person eating this ready-to-eat food might get sick from the liquid around the uncooked food. So at the very top of the refrigerator should come the ready-to-eat food, then unwashed vegetables, fruits, then beef, then ground meats, injected meats or egg dishes, and at the very end the poultry, because the poultry or any chicken should be cooked at a higher temperature than meat. So keeping it at the very low is the safest. Storing food, ready to eat food which needs time and temperature control for safety can be stored only for 7 days in a fridge. So for example, any cheese we buy from the supermarket should be kept only for 7 days, and then if it's not consumed, we get rid of it. Store items with earliest use by expiration days in the front so that they are used before the other items, and do not overload fridges or freezers because it impedes the flow of air, so the temperature will get higher in the fridge. Preparing food, general preparation practices, all workbenches, equipment and cutting boards must be clean. Only remove food from the fridge that will be prepared immediately. To prevent pathogen growth, thaw food in a fridge, water, microwave, or do not leave food to be thawed in room temperature, because this leads to the doubling of the microorganism count present. Cutting boards should be separated. We should not use a cutting board for vegetables that is used for food, for meat, because this can lead to transfer of microorganisms. We cook food to safety temperature by using thermometers. Not a whole lot of us use thermometers usually during cooking, but it's very important in hospitals and where people with immunity problems are served food, to make sure that the temperature, the internal temperature of meat, poultry, and fish is reached, and bring sauces, soups, and gravy to a boil when reheating. And specific instructions for cancer patients, because many of the cancer patients, even when they are taking chemotherapy, they are, at the end of the day, they go home, so people taking care of them. For example, when my father was taking chemotherapy, I didn't know all this, so we usually fed him what we were eating, while this is not completely right. So the most important do's and don'ts for cancer patients: do wash your fresh fruits and vegetables with clean running water. Do wash your hands often with warm water and soap for 20 seconds. Do sanitize utensils, cutting boards and countertops, especially with chlorine, diluted chlorine. And chlorine is very safe to be used with food if it's diluted. Do use separate grocery bags for raw meat, poultry, or seafood. Do not, when shopping in the supermarket, do not put poultry, chicken with meat all in the same bag, to avoid transfer of microorganisms from one type to the other. And do buy only pasteurized milk, soft cheeses, anything pasteurized. They cannot be allowed to take fresh juices, and they also should preferably take pasteurized eggs, but pasteurized eggs are not available here in Egypt, so this part is not really applicable here. And do thaw food in the refrigerator, in the refrigerator in cold water or in the microwave. Well, do remember to clean lids before opening canned food, because usually the lids are not clean. The most important don'ts: don't rinse raw meat, poultry, or seafood with running water, because running water leads to splashing of water droplets, which could lead to the splashing of bacteria to other surfaces. Don't use a dirty cloth to dry any surface. Preferably use paper tissue. Don't use the same cutting boards as we said before. We preferably have a cutting board for each type of food, and preferably separate them by color. Red, for example, for meat, blue for fish. Don't use raw eggs, as we said before. They have to be very well cooked. Don't leave perishable food out at room temperature for more than 2 hours. Like rice, like the cut tomatoes, anything should be left not more than 2 hours. If it is left more than 2 hours, then preferably it should be thrown. Don't throw food at room temperature, such as on the countertop, which we used to do before, that we take out anything from the freezer and leave it on the countertop till the next day. And there's a very nice poster the WHO did. It's called 5 Keys to Safer Food, and this can be easily printed from their site and put in a kitchen in the hospital, put wherever in your own kitchen, anywhere where it is mandatory to keep food safe. It's reviewing all the topics that we discussed before, like keep clean, separate raw and cook thoroughly, keep food at safe temperatures, and use water and safe water and raw materials. Thank you.
Did you use vitamins or oligoelements?
Macronutrients, glucose, amino acids, either standard amino acids or from applications or interpretations, and lipids, finally the last generation, which contains olive oil, omega-3 and omega-6, vitamin E. Micronutrients are added, trace elements, as soluble vitamins, water soluble vitamins, and organic phosphorus according to the need of the patient. Electrolytes can be added as the daily needs for the patient if the
Thank you. Another question about TPN or orange. Can you use the microphone, please? Because
She's asking about is there a training course or certified place for financial nutrition. في resources لو مفيش حاجة زي كده أنا عايزة self-learning. You have Aspen guidelines free on the internet, and for compounding all in one bags, the only company available for education, learning, and giving you all the information you need is the Genius Capital. Because it's the only company in the world that having all the macro and micronutrients can be put in all in one bag. Other companies either have 1 or 2 products. So all in one bag can be done by the other companies.
But there is systems of we have 3 components, okay? In the same bag there is 3 components, the amino acids, glucose and lipids. And just before to use, you can push on the bag and you mix just before
During the preparation, there is specific order for mixing.
Yes, I know. But
After preparation, if we store it in a refrigerator till the patient use it, it has to be out till it reaches the room temperature. Then we have to shake it slightly and hang it to it. على حسب المستشفى.
I have a question for the food and safety. Could you give some comment about the expiry date? Because it's the expiry date, because it's very important, because for example for yogurt or like that, the people say, okay, it's the expiry date is in 10 days, I can eat it. Okay? But if you keep outside of the fridge, could you comment on the problem of expiry date? Because I think it's very important.
Yes, many people they don't read. Many people they don't read the expiry dates on boxes or cans, and they continue and they say as long as I think or its taste is what I'm used to, then it's safe. But the problem is with food safety that microorganisms which start to develop in food after the expiration date, they cannot be seen. So there might be a large population of microorganisms we don't see, but we just feel that the taste is the same. Sometimes there is a discussion that the food producers they put very small expiration dates to force people to throw old items and buy.
The same for the drugs.
But I'm a pharmacist and I was working in Novartis, the pharmaceutical company. Usually the expiration date was depending on stability studies.
Yes, but the stability is very limited. For example, it says three years. But if you can see, maybe it's stable for 10 years. Okay? But it's more regulatory problem.
Yes.
For example, I work about stability of monoclonal antibodies. I know, okay, that it's more stable than indicated by the company.
Exactly, it's the same for food. So preferably when we buy food, we choose items with a very long, I mean that the expiry date is still after maybe 1 year to avoid reaching that time when we have to decide should I throw it or should I continue. After all, I paid money in this item. But regarding ready-to-use food, like for example the cheese we buy, it's something not related to the companies at all. It's something related to food safety. That after opening it, after 7 days, even if it's in the refrigerator, it should be thrown because it develops large amounts of microorganisms. Maybe sometimes when if we are healthy, we say, okay, I'm healthy, I can eat it. But if somebody is inspecting kitchens or food serving facilities in a hospital or in any place where they serve, like nurseries where they serve little children, no, these rules should be followed strictly because we are talking about health. And the problem with food safety is that very few people really report any foodborne outbreak, illness outbreak. Usually it's just we take the medication and it's forgotten after 2 days.
Thank you. Thanks a lot. Sorry for the technical problems. Okay, you can have
And I'm a lecturer at the German University in Cairo. I teach molecular genetics, pathology, and pathophysiology. I also finished clinical professional diploma in clinical nutrition from the American University in Cairo, and currently I'm halfway finishing my master's degree of clinical nutrition in the Ain Shams University in Cairo. The topic here is oral chemotherapy, food-to-drug interaction. Since it's an oncology program, I have nothing to disclose. Starting the oral chemotherapy, the occurrence and the start of the use of oral chemotherapy actually started in the 50s. And it was expected by the year 2013 that the oral chemotherapeutic agents to take over about 25% of the medications for cancer patients. So currently the administration of oral chemotherapy represents one of the major focal points. And also, out of 400 clinical trials over on chemotherapeutic agents, 300 of them, like 75%, are oral therapies. It has a lot of advantages, and that's why a lot of research is being processed on the oral chemotherapy, because it attracts patients. There's a lot of patient convenience in oral chemotherapy. It does not interfere with the activity. The patient does not have to stay in the hospital for hours to take his parenteral therapy. It improves the quality of life, of course, and there's avoidance of pain and of the parenteral nutrition. However, and also, one more point, some types of oral chemotherapy are actually more effective than the parenteral chemotherapy. However, there's a lot of challenges in the oral chemotherapy. One of them is the misconception of the patient that they think that the oral chemotherapy could be less toxic without complications, which is not true. Another challenging is that the healthcare provider should monitor the intake, the compliance of the patient. And one of the major challenges is since it's orally intake, it could interact with fluids, it could interact with food intake. So, what does food-to-drug interaction mean? It's a double way. It is defined as the alternation of pharmacokinetics or pharmacodynamics of a drug or nutritional element, and it's the effect of the drug intake on the nutritional status of the patient. And of course, as oncologists and pharmacists, you know that the most challenging issue in the cancer patient is the nutritional status, because around 20% of patients die out of nutritional deficiencies rather than the chemotherapy and the cancer. So if there is a drug-to-food interaction that actually affects the intake of nutrients, this is going to be challenging. And if the food interacts with the intake of the medication, that will not give the same efficacy and the expected results, it's going to be a problem. And this is why, as pharmacists and physicians, I've been teaching, although I'm a physician, but I've been teaching pharmacists for 10 years, and pharmacists are not the dispensers. They're not just to dispense medication. Pharmacists should know what advice should be given to the patient while taking the medication. In general, direct effect, most of the diets or the food has a direct effect on the medication, which is probably the pharmacokinetic, which will in turn affect the pharmacodynamic levels of the medication. It's very common. The drug-to-food interaction is very common, and it occurs, it constitutes 4% of death among cancer patients. However, such drug-to-food interaction, as in a percentage, it represents minor people because it's variable, it's highly variable. It does not necessarily be toxic. In 40% of the patients, it's insignificant. It has moderate efficacy in 50% of the patients and has severe efficacy in 10% of the patients, which means that although there's a lot of variations between drug-to-food interaction, it has an effect in 60% of the patient, an obvious effect on 60% of the patients. This variability between one person to another, and that's why you cannot say what's 100% contraindicated as food, but you suggest according to the data we have. This variation is caused by the pharmacogenomics and pharmacogenetics, because different populations are having different genomics and genetic mapping, and this is why there's a huge variability. However, I'm going to talk about the most common medications used and the most common expected drug-to-food interaction, like the afatinib and lapatinib. These are tyrosine kinase inhibitors. Here, the high-fat meal intake decreases the Cmax and AUC, which will interfere with the efficacy of the medication. Another example, lapatinib. The total food intake exposure increases the adverse effects. Some other medications are preferred to be taken on empty stomach, like for example, lomustine or before bedtime, because it decreases nausea. And it's highly recommended to decrease the manifestations like nausea and vomiting, and in order to decrease the cachexia and anorexia that patients with cancer suffer. So if you know that this medication is preferred to be taken on empty stomach before bedtime, this will decrease nausea, so it will decrease a huge side effect of this medication. Dasatinib is a tablet that contains lactose. And we have a lot of patients with lactose intolerance, so such medication should be considered in lactose intolerance patients. Also, nilotinib has the same effect. It has lactose, so it should be considered in trans patient. One more thing about this specific medication, it could be associated with applesauce. Applesauce is like the pureed apple. Sometimes the patient would hate to take the medication and they prefer to take it mixed. It cannot be done on all medications. Could be done with this one. Some other drugs are contraindicated with excessive folate supplementation. And folates in general, or folic acid in general, is present in green leafy vegetables. If there is increased intake of folate supplementations, more than the 100 RDA, 100% RDA, it's going to make side effects using this medication. Mercaptopurine should be avoided with calcium. And when anything is contraindicated with calcium, this means that the patient has to leave around 2 hours before the intake of the medication, a gap of 2 to 3 hours before the intake of the medication and the calcium, so that they should not be mixed together until gastric emptying occur. Here the methotrexate, for example, it should be taken with plenty of water, and you should maintain very well hydration in this patient to avoid kidney damage. Also, the concomitant intake of alcohol with methotrexate is highly contraindicated because it leads to severe hepatotoxicity. And yes, we should say this to the patients, even the Egyptian patients, because yes, a lot of patients, they take alcohol. We have to face this, so it's one of the recommendations. Imatinib could be taken with water and apple juice. It should be taken with food, actually. Should not be taken on empty stomach. We have here getisinib. This is a very interesting medication because it can be dispensed with water and it can be given in the nasogastric tube in case of the patient cannot swallow, which is not contraindicated with food. Cyclophosphamide has to be taken with increased amount of fluids to avoid problems in the bladder. If you can see these figures and these tables, every medication is clicked whether it should be taken with food or an empty stomach, or if it has a grapefruit effect. Okay, and I already left the citation of this huge paper. It was a big study, meta-analysis study made on around 58 medication, oral chemotherapy medication, and all of these tables are the results of this study. Some drugs are having moderate grapefruit effect, like etoposide, and it's not only with grapefruit effect, it also interacts with orange juice and tangerine. So it should be avoided with anything that contains vitamin C. I can read all the medications. There are more than 58 medications, so I'm not supposed to read them all because of the timing. I just wanted to highlight the most common. Other medications like mercaptopurine, it's proved that it interacts with cow milk. So it has to be separated, completely separated, like 2 to 3 hours from cow milk. Another example, tamoxifen, which is a very successful anti-cancer therapy, and it's used specifically in BRCA-mutated breast cancer patients. It has very negative side effects when taken with sesame seeds, should be avoided. And here in Egypt, we love sesame seeds. We eat bread with sesame seeds, we eat crackers with sesame seed, and they should be separated. They are totally contraindicated to be together. Some foods that affect the CYP3A4, which is involved in the metabolism of the medication. One of them is the grapefruit, the Sibyl orange, which is like tangerine, and the pomegranate, l'oromon. They interact with the food. Specifically, the grapefruit effect was shown on several studies, how it affects the tyrosine kinase inhibitor, decreases its amount, decreases its concentration, and decreases its efficacy. Also, it has a negative effect on the etoposide medications. Garlic studies are now currently made on garlic. Still no significant side effects, but it was found that it can affect the metabolism of certain medications like the docetaxel. It's not significantly measured, not highly significant, but there is a possibility. And since there's a possibility, you should advise your patient not to take a lot of amounts of garlic. And in general, if the patient is taking limited amount, ask the patient not to change the amount of supplements and food intake with his medication. For example, he cannot on one day take anything cooked with a tiny piece of garlic, and on the next day he eats garlic sauce, huge amount of garlic sauce. He needs to fixate the amount into a limited amount. So since oral chemotherapeutic agents are highly successful and preferred for the patients, yet we need to monitor its intake and its drug-to-food interaction. Such monitoring will minimize food-to-drug will minimize a lot of complications, achieve the intended side effects, improve compliance in the patients, improve the quality of life, and decreases the complications of the treatment and of the cancer itself. Thank you so much.
Thank you so much for this very, very important and interesting presentation. There is some question in the audience. Yes, please.
Regarding the
The microphone.
regarding the interactions you mentioned, are these written in the leaflets of each of these
So
drugs?
they're now starting to write it, and this is why. Let me tell you one thing related to your question. They made a study, I think in 2011, and they examined around 100 patients, asking them whether they received correct info from the physicians and pharmacists. And they found out that around 50% of these patients did not receive the correct info. And they also found out that the patients are ready to hear the correct info, which means that some of them are written and some are just published. It's a publication. Now the pharmaceutical companies are trying to write down the whether there is any correlation with drug with food interaction. The problem is the variability, and again, this is why what I'm insisting about. There is a huge variation between different populations due to the genomic and genetic variants. So I think every country should make their own guidelines according to their own experience, according to the patients. So even if the pharmaceutical companies did not write this on the pamphlet, we should read about it and we should give the advice. Especially, it's a very simple advice. It will not affect the quality of life. Like, you should not take calcium or yogurt 2 hours before this medication and 2 hours after this medication. It's a very simple task. There will be compliance, and we will avoid the side effects.
Physicians do not usually give this kind of advice.
I understand, and this is why in oncology, the team is not only about physician. I'm a physician myself, but there should be, and I think Dr. Zena will agree with me, there should be a nutritional consultant, or a registered dietitian, and a clinical pharmacist in treating the patients.
Well, and in addition, the problem is we have more and more drugs with very limited amount of patients. Because, for example, new tyrosine kinase inhibitors are limited to a small population because it's specialized medicine.
Yes.
And there is absolutely no data about interaction with food, okay? Because there is maybe a clinical trials with, I don't know, 100 or 200 patients, but in very controlled condition, and absolutely no problem, no idea about the interaction with, I don't know, hummus or as you want, okay? It's a real problem, and the problem is the drug, it's not so active, okay? And if the patient don't take the pills because he have a side effect, for example, we lost all the efficacy, okay? It's very, very important. This problem is important. Another problem is, it's not exactly the drugs, but it's the problem of alternative medicines, okay? And herbs, for example, because it's supplementary materials or supplementary alimentary product or like that. It depends on the regulation in each country, but it's a lot of extract of plant or like that, of tisane, or if you want.
Like
and then
for example.
it's a mess because there is a lot of interaction, and more than 80% of the patients, the cancer patients, take alternative medicines. When you ask as medical doctors, do you take something? No, doctor, I don't take something.
Exactly.
Okay, but
That's
it's
right.
not true. There's
It's not true.
a lot of herbs, a lot of, I don't know, homeopathy or whatever you want. If you take homeopathy, there is no problem of interaction. Okay,
Yes.
but if you take some plants, there is a lot of possible interaction. It's a very big problem.
Yes, definitely, and all cancer patients should not take any vitamin or supplementation unless getting referred to their doctor. Because the amount of interaction between supplementation, but I did not talk about that because yesterday we had a drug-to-drug interaction therapy, and Dr. Amr Shafi was explaining the link between the drugs and the supplementation. That's why I did not mention it. But of course, there's a huge link, and it should be monitored. And one more thing. Some doctors, they have a system on their computer system, certain programs that contains drug-to-food interaction. But recent studies, they found out that these computer systems are actually variable between a physician to another. So after I studied this, I think that we collect all the data and give all the data, the possible data for the patient, even if it's not 100% approved, but out of safety. You know, until we prove it with a prospective study made on thousands of patients in order to have an evidence-based project.
Another question or comment? I think so, to conclude, I think the important point as underlined by the medical doctors is the role of clinical pharmacists in the oncology team. I think
Yes,
it's
yes,
very important
100%.
because in France you have a long experience of this team because during the discussion of the patient, the pharmacist is mandatory by the law.
Exactly.
By the law in France, you must have in each discussion about the patients, clinical discussion for chemotherapy, the pharmacist must be there. Okay? And it's very important because we are not doctors, we cannot have to discuss the X-ray exam or like that. But for pharmacokinetics, drug interaction, food interaction, or TPN, or like that, it's very, very important.
Yeah, the importance of the clinical pharmacist in the oncology team is equal as the importance of the oncologist himself. The clinical pharmacist has to understand all the interactions, the indications, which is definitely your job, and even the nutritional aspects behind this in the patient.
Okay, one last question. If not, thanks a lot for all presentations and see you later.
I have a question.
Yes? Question, sorry.
You mentioned about contaminants in foods. What about black honey and iron?
They can be considered as contaminants. Iron, yes, they are considered as chemical contaminants.
Black honey, everybody knows that it contains iron. But black honey doesn't contain iron. It's only a contaminant from the unistils used for preparing the black honey.